Good afternoon, everybody. Welcome to today's webinar on what we've learned about COVID-19, health risks and prevention. I'm Scott Ernest, Associate Director for Construction in NIOSH's Office of Construction Safety and Health. As most of you probably know by now, CPWR and NIOSH are holding this bi-monthly COVID-19 webinar series for the construction industry. You can access recordings from the whole series through a playlist on CPWR's YouTube channel. It's been over 6 months since the COVID-19 pandemic began. Throughout that time, we've all tried to stay informed. We've tried to help keep you up to date through the webinar series and other resources. However, as we all learn more about the virus, information and knowledge is changing. Today, Eileen Betit, Director of Research to Practice at CPWR, will briefly introduce a new CPWR planning tool to help construction employers more easily develop a COVID-19 exposure control plan for their job sites. Following that, we'll hear from Dr. Rosie Sokas and Dr. Melissa McDiarmid about what's been learned regarding the virus, how it spreads, and what we can all do to prevent it. Dr. Sokas is a professor in the Department of Human Sciences at Georgetown University School of Nursing and Health Studies, and a professor in the Department of Family Medicine at Georgetown University School of Medicine. Dr. McDiarmid is a professor of medicine and epidemiology and public health, as well as director of the Division of Occupational Environmental Medicine at the University of Maryland School of Medicine. And Chris Kane, executive director at CPWR, is here to moderate today's webinar. And after a short presentation from each speaker, she'll lead us through some discussions. We did receive a number of questions during the registration process, and we'll address those first, followed by live questions as time allows. And with that, I'll hand it over to Eileen Betit to get us started. Eileen?
Oh, thanks, Scott. So through this webinar series, we've received many requests from stakeholders for information and resources to help them prevent the spread of the disease on job sites. So in June, one of those requests was for a planning tool similar to the one that we had developed for silica that's on our silicasafe.org website. Jen introduced our new free online COVID-19 exposure control planning tool that Rick Reinhardt, our Deputy Director, Hannah Eck, and I developed. Given the industry need, we launched it last Thursday, and we welcome feedback. So as people start to use it, please don't hesitate to send us ideas for how we can improve it or anything that you see that needs to be changed. So I'm going to start with the homepage. The section on the homepage, Why Create a Plan, provides information on why you should consider a job site-specific COVID-19 plan as recommended by CDC and OSHA. The How It Works section briefly walks you through how the tool works. Register, log in is completely optional. We've set this up so anyone can use this tool to create a plan, but for those who register, they have the option of saving their plans so that they can retrieve them and edit them in the future. All you need to do to register is to have an email address. You won't be asked for any personal information. And just like with our Silica planning tool, we developed a firewall between us and the plans created. So if a user has an issue with retrieving their plan, what we do is we bring in the third-party web developer to address it. So at no time do we ever try and access your plans and to see what's in them. You can see in the box with the red lettering, there's a link to our COVID-19 Construction Clearinghouse, and this is a repository of information for the construction industry. We've added a planning tool section to that site that's directly connected to this new exposure control planning tool. And finally, the big green button that says Begin Your Plan takes you to the first of the 4 steps to create your COVID-19 exposure control plan. So we'll start with step 1. And you'll see at the very top of the screen circled in red that there's an option to give your plan a name. And this appears in every step of developing your plan. So if you don't do it initially, you can do it later on. So in step 1, you'll be asked to identify the COVID-19 exposure risks on the job site and in an office or a trailer setting. You can select multiple risks and multiple controls for each one, but you must select at least one risk and one control to move on to step 2. And this is the only step that requires an entry before moving on. Throughout the steps, you'll see these blue circles with an eye in them, and if you click on one, you'll be taken to a pop-up box with an explanation of the item it's next to. If there's specific information in the clearinghouse related to the topic, the pop-up box will include a link to that information. And this slide shows an example for designating separate points for entering and leaving a job site. So it shows you if you clicked on that link, you'd be taken to a special section on our clearinghouse. In step 2, there's space to describe the process for screening workers and visitors, and it includes a series of prompts to help you think through what to include in your plan and space to describe what will be done. For example, who will be screened, how the screening will be performed, who will do it, and how sick and exposed workers will be handled. Step 3 addresses training, and like step 2, it includes prompts and space to describe the training that you'll provide, including who will be trained, how, when, and where the training will be conducted, and the topics that will be covered. Step 4 is where you'll enter other information to complete your plan, such as your company's name, the project name and description, the person who prepared the plan, the person responsible for implementing the plan and their authority on the job site, and any other information that wasn't covered elsewhere in the plan. So at the end, the final plan is populated with all of the information that you entered in steps 1 through 4. And at the red circle at the top, I apologize that you can't see it better on this screen, but it's each of the steps. And if you click on each step, you can go back and edit anything that you had put in earlier. And when you're done, you can download a PDF, you can email it, and you can print a copy of the plan. And if you've registered and logged in, then you can also save that plan and retrieve and edit it at a later date. So that's a very quick overview of this new planning tool. And again, I want to emphasize that we welcome feedback. There's a link on the bottom of the planning tool that you can click on, and it'll provide an email address where you can send in your comments, or you can reach out to me directly at CPWR. Thank you.
Thank you very much. And our next speaker is Dr. Sokas. Dr. Sokas?
Thank you, and I appreciate, Scott, your introduction, and I appreciate Eileen's description of what CPWR is currently doing to make this much more accessible. I'm also grateful to NIOSH and CPWR for all the wonderful work you guys have done throughout this whole event, and to each person signing in today. So it's only been 8 months since we first heard the first inklings about coronavirus, the novel coronavirus, but in some ways it really seems like it's been years. And a lot of work has been done originally looking at all the different coronaviruses we knew about to see what we could learn from analogy. So just to remind everybody, back in December and in January, we were seeing the 7th coronavirus to reach human populations. The first 4 have been around for, it's thought to be hundreds of years. Collectively, they're one of the major causes of the common cold, and we're familiar with them. In the last 18 years, 2 new coronaviruses emerged. The first was the severe acute respiratory syndrome, which was stopped after it had infected about 8,000 people globally, about 10% of whom died from the disease. More recently, the Middle Eastern respiratory syndrome jumped from camels to people. It's been a little bit harder to control. There are still cases that pop up, but in general, it's had fewer cases worldwide, but they've been more lethal. It kills about 30% of the people who get infected. And then now we go to our new novel coronavirus, and there are about, 60 other coronaviruses in animal populations waiting in the wings, as it were, for their chance on the stage. But let's focus on SARS-CoV-2 and what we've learned since this emerged. So the big news, the thing that's really made a huge difference, is that about 40% of the people who were infected with this virus have no symptoms. Unlike MERS, unlike SARS, where you couldn't transmit the disease unless you were sick, and you were pretty darn sick with it, here you can transmit the disease before you get any symptoms, or even if you never get any symptoms. So that's why it's been a global pandemic to the extent that it is right now. The other things we've learned have been confirmed, that men die at slightly increased rates than women, that older ages for sure are big risks. But what's interesting here is that it's not as if it just bumps up at a magical age of 50 or 60 or 70. When children reach the age of 10, their risk for acquiring symptomatic disease starts to climb, and it climbs through the 20s and 30s and 40s, and that's what we're seeing right now with the spike that's occurring throughout the United States. It's plateaued. It's at a pretty high level of plateau right now, but basically currently we're seeing younger people with the disease disproportionately. We've also seen the disproportionate impacts on racial and ethnic minorities. We know that there are a variety of underlying conditions. These include cancer and immunosuppression and lung disease for sure, but also obesity, diabetes, and hypertension. And this has been quite striking because we think of obesity and hypertension not really as disease states, but as risk factors for other diseases. And the fact that they are risk factors in this disease is a little unnerving. Diabetes is a huge risk factor. So these are important considerations that we've learned. Now, if you're among the 50% almost of the adult population who are hypertensive in this country, the original discussion around hypertension was worried about some of the medications we use for hypertension, because the receptor sites for the virus include the ACE2 receptor sites, and many of us are taking ACE inhibitors as our antihypertensive agents. Well, there was a lot of speculation back and forth. People were kind of worried about it. In point of fact, there is no worry about using ACE inhibitors. In fact, if anything, they seem to be a slight bit protective. So everybody who's on their antihypertensive medication, just stay on your antihypertensive medication. We've seen extraordinary risks in some job categories like meatpacking. We've seen increased evidence for airborne transmission, that initially the droplet transmission was what everybody talked about, and the contact surface transmission. But we learned that 6 feet is not a magic number, that droplets dry out and stay suspended in the air. And like other viruses before them, this virus can still be found in the air in infectious amounts. So we're recalibrating what we're worried about in terms of transmission. Now, we still want people to wash hands. We still want people to have cleaning protocols and clean their equipment and make sure that bathrooms are clean and available, and that there's soap and water and hand sanitizer available. But having said all of that, we're slightly less worried about surface contact transmission of repeatedly touched surfaces. You still want to obviously wash your hands. You still want to clean them off, but it was originally thought that this was the major route of transmission, and it's clearly not. We've had an increased appreciation for the severity of the disease outcomes. So I think everybody here knows about the bleeding and the clotting and the strokes and the heart disease and the worsened pneumonia, but also the neurologic symptoms that come along with it and the cardiac symptoms that come along with it. So it's a wicked infection in that there's all kinds of stuff going on with it. Last couple of points on this slide, there's the fact that we have this relatively high plateau going on right now. Nevertheless, we're still seeing about half the number of deaths we were seeing back in April when New York City was getting hit so hard. And that's actually because we know now that there are some, partly because of younger people getting exposed, so that's clearly part of the issue. But the other part is that we have some things that we know better than we did before. We know that one of the antiviral agents at least reduces the length of hospitalization, even though it's not a complete game changer. There's still work going on trying to find that. But steroids are really important for people with severe diseases, people who may have to go on respirators, that sort of thing. They really reduce the body's own inflammatory response, which is responsible for some of the most severe outcomes. And then there are other things like positioning the patient during ventilation and that sort of stuff, which is helpful. The other thing we've also learned is that the testing, the nasal swab testing that we do, picks up and reports out dead viral fragments as well as infectious viruses. So nobody recommends it anymore for follow-up. If you've had an infection, you're not waiting to see if that test is negative. You're just going to wait 10 days after the person feels better. Okay, now this is one of the huge things we've learned, and you can look at the number of cases across this line here for American Indians, for African Americans, and for Latinos in the United States. They have almost 3 times the risk of acquiring the disease as the white population. This is because they are much less likely to be able to work from home. They are much more likely to be in essential services, to have to take the bus to work, to live in multi-generational housing, and all of these things are social determinants of health that make this virus spread throughout these communities. The risk for hospitalization is even higher among Native Americans and African Americans and Latinos, almost 5 times between, and in fact above 5 times. So this is an enormous increase, and this is due to the health disparities, again, related to social determinants of health in terms of obesity and diabetes and hypertension in these populations. And then there's an increased risk of mortality, most striking among the African American population, where you wind up with twice the mortality from COVID-19 as you see in the white population. Okay, let me see if I can move us along here. Okay, sorry. All right, now a lot of the things that we know because of news reporting. So originally CDC, apologies to anybody here from CDC, but CDC was not reporting on racial and ethnic disparities. It was the New York Times and a number of other news outlets that were noticing these differences locally. And now the CDC has gathered that information that I just showed you. It's tried to ask about occupation, wasn't getting much back. And so right now, we don't have any information being collected systematically about occupation or industry. Again, it's all coming from news reporting. So for example, we can't tell you if plumbers and pipe fitters have worse outcomes than stonemasons, for example. We just don't have that level of detail. There's been arguments about what the true numbers are. Now, I know you've all heard this, and you probably have heard the controversy around it. We pretty much think that for diseases, we've got it, or infections, we've got an underestimate because we haven't done comprehensive testing. For fatalities, there's probably, most experts agree, there's probably some undercounting as well, particularly in places like New York that got overwhelmed and people were dying at home, and some of these weren't being definitively captured. You've heard people say, well, this is only happening to people with, other things going on. But in point of fact, I would tell you that if I have hypertension and I walk out the door and cross the street and get hit by a bus and get to the hospital, and it turns out that my hypertension is a little tough to manage, but I die, I'm not dying because of my hypertension. I'm dying because I got hit by the bus. COVID-19 is the bus. What's the deal with herd immunity? So I want to go and have a little kind of clarity on that. This is an older slide that just kind of shows the basic concept. The little blue people are not immune, but they're also healthy. They're not, they're doing fine. The little yellow people are immune and healthy, and the little red people in this slide are sick and contagious. In point of fact, for COVID-19, you could be infected and contagious. You don't have to be sick. So you've got these 2 sick people in the first slide who then get in touch with a whole bunch of healthy people and make them sick or make them infected. We'll call it infection now. In the second set of slides, you see a few scattering of immune people, but there's not really enough of them. Obviously, there's no social distancing going on in these little cartoons either, but you're not seeing enough of the healthy people to really prevent, you're not seeing enough of the yellow immune figures to really prevent all these blue people from turning red and infected. And then in the final grouping, this is what you want to have. It's not 100%. This little red guy is still going to infect this little blue guy, and you see that down here. But if you have enough immune healthy people to kind of separate the non-immune from the infectious, then you wind up doing really well, and you can protect some of these healthy but non-immunized people. Now, you want to achieve this through a safe and effective vaccine. You really don't want to take a disease that kills, even if it's only 0.5% of the population, which is what we think is going on now. Nevertheless, that's going to be over 1 million people in the United States if you try to do it through getting everybody infected. So we're hopeful that we're going to wind up with a safe and effective vaccine. So the other couple of things I just want to mention are for all of the cold-causing coronaviruses, as well as for this one, for SARS-CoV-2, we have good evidence that ultraviolet radiation weakens and decreases the infection itself. Now, does it does it directly because parts of UV radiation actually can kill the virus, but it also is thought to work because it improves the ability, our ability to create vitamin D. So we rely on sunlight, UVA, to create vitamin D. So what's the story about vitamin D? And you've probably all read about this. There's a ton published. Vitamin D levels, we know ahead of time, we know right now, are much lower among people who are sick enough to be hospitalized with COVID-19, and they're even lower among the people dying from COVID-19. And we also know historically that vitamin D deficiency is associated with older age, with diabetes, with obesity, with hypertension, and it's also associated with racial and ethnic minorities, particularly with people of color who live in northern latitudes. They historically have lower vitamin D levels because of the way we process vitamin D through our skin. And so the question is this just a bunch of coincidences, or is there something causal going on? And we don't know the answer. There hasn't been a randomized control study where half the people were given the vitamin D supplement and the other half weren't and all of that. But the downside for vitamin D is not much. If you take the regular over-the-counter amount, which may be 2,000 international units, you would have to take 15 to 20 times that amount in order to get vitamin D toxicity, which does occur. So it's not like it doesn't occur, but it doesn't occur at the levels that that most people are taking supplements. So that's just information to share. The mortality rates in Europe for COVID-19 have been shown to be related to latitude. They're worse at the higher latitudes. And that was what started people getting interested in the vitamin D link. But in point of fact, you also have clear information that ultraviolet light kills the virus. And this is the last slide. I'm just going to go through a laboratory experiment where they, across these little x-axes here, you've got the number of minutes that it takes for combined UVA and UVC irradiation to kill a sample of SARS-CoV-2. And it doesn't take much. It's 9 minutes and it's gone. Even sooner, in 3 minutes, you get inactivation of the virus, so it's no longer effectively transmitting disease. Now, looking at UVA, not doing so great here. UVC, on the other hand, this is looking at the amount that you have to use. So you have to use a fair dose. But if you're cranking up the dose of the UVC, you are going to get that virus. And that's led to lots of discussion and investigation of other approaches to use ultraviolet radiation for engineering controls in a variety of settings that might help to not only prevent this pandemic, but also reduce exposure to this virus, but also to seasonal flus and other viruses. And with that, I'm happy to turn the program over to Dr. Melissa McDiarmid, who is a dear colleague and one of the world's experts on respiratory protection for worker protection.
Oh, thanks, Rosie. I think that was a little overboard, but anyway, thanks very much. Afternoon, everybody. It's afternoon where I am. I very much appreciate the invitation from NIOSH and to be here among my colleagues. I was asked to present something new, and I thought I would talk about masks because they've become quite controversial, have they not? To the point that I guess there is actually some people being so upset about it that violence ensues. So I wanted to talk a little bit about what's up with masks. And when I'm talking here, in this case, it's mostly about the masks that the public is wearing. So I'm not talking about respiratory protection, which I know many of you on the line today have some occupational experience with. I'm just talking about face coverings that are recommended for everyone who's around others in public. And just to say, acknowledge that the reason for this recommendation from public health experts is to prevent asymptomatic spread. So this is a very different reason for wearing a mask than we in occupational health recommend people to wear because they're in a workplace where they're being exposed to a hazard. So in this case, the public health leaders are suggesting, because of so much of the asymptomatic spread that Dr. Sokas mentioned, that in fact, the person wearing this mask, this woman here, is the source if she unknowingly is infected with the virus. So she's wearing that mask to protect the rest of us. And there was certainly a lot of mishandled public health messaging around this in the beginning. And for people that are frustrated about that, I would say to give a little coverage to CDC and other public health agencies, the idea that so much of this virus was asymptomatically spread was a game changer. And it was not anticipated because, as Dr. Sokas has already said, the people who had the other types of coronaviruses like MERS and SARS were sick, and they knew they were sick when they were symptomatic, spreading disease. So this really kind of upset the apple cart of what the popular belief was, which is why it took so long, and it seemed to be there was some foot dragging about masks and why the recommendations changed. Okay. So I do want to say a little bit about how they work and don't work. Masks can capture particles using two methods. I think we tend to focus a lot on the idea of filtration, which is that the mask acts as a barrier, basically, and it can exclude a particle based on the size of the particle. But I'm going to spend a little bit more time on this. There's also another physical method that benefits the capture that a mask can achieve through an electrostatic force. The mask is charged, and so it can exclude a particle based on the particle's charge. So it's sort of like a 1-2 punch, and these two methods together enhance the efficacy of the mask to keep you the unknowing asymptomatic carrier, from wrongly or again unknowingly putting out infectious viral particles into your breathing zone and beyond. For cloth masks, what we know now is that greater the density of the material, which we would say here is thread count. You know, when you buy fancy sheets, sometimes it'll actually tell you on the tag what's the thread count. And the higher the thread count, the better the quality of the sheet's supposed to be. Well, it turns out that's also true for the better the filtration for that piece of cloth acting as a face mask. Here's the kicker, however, just like in respiratory protection, gaps in the fit of a face covering will decrease the efficiency of the filtration. So I thought this was a really neat slide that I found that sort of depicts the kind of 1-2 punch, if you will, the 1-2 different types of protection that a regular old mask can provide. So the first go through here is in the green piece. This is depicting the filtration efficiency of the mask itself. So here you see a bunch of different particles of different sizes, and they're going to be coming through the mask. Now this is, the way this is drawn, it's to depict an organism or a virus or a particle coming toward the wearer. So it's not exactly drawn the way I would have drawn it to show the idea of we're being protected from the person who's the source patient, who's kind of back here. But the point being, whole bunch of particles, different densities, different sizes, but a bunch of them get captured in the green such that only a few of them make it through to hit the blue. And the blue has provides an electrostatic filtration, so it can pick up some other particles. So I think the best explanation I've heard about the electrostatic filtration is if you think about when you're pulling clothes out of the clothes dryer and you know how everything sticks together, that's electrostatic charge that's making your socks stick to each other. And in this case, you can use that, and our engineering colleagues design these masks to make that filtration work for us and permit charged viral particles to stick to this charged filter. So you've got these two different ways of protection from the viral particle that's in the air. We're getting a little bit in the weeds here, but I thought some of you might be interested in this. The non-medical masks, which is what we're talking about, which are the ones that a lot of people are making, or you can buy them, these general purpose, general public use masks, it's important to know that one cloth does not equal another. There's a huge variation, and there's no clear and easy guidance about possible for structure. So right now it's a free-for-all out there. And the efficiency of the mask, therefore, needs to be measured. It can't be predicted. So you have to, if you were, looking for something to buy, you have to have masks show data for how well they work, just like we would require, NIOSH requires the people that make N95s to show data for, and then to have their products pass some type of performance inspection. Anyway, I'm just showing you here, and I like colors, so I like this slide. There's a lot of different ways fabrics are made. This looks like a regular woven fabric, but here you start to see kind of complex, I guess, organizations of threads, and this looks kind of chaotic here. It looks like pickup sticks, but the way the threads are organized also influences how well they act as a filter. And over here, I just want to show you, this looks really kind of chaotic, and these are examples of spun yarns, and this is the kind of stuff that's used in like surgical masks, so it's not woven, and that's a big deal to people who are the engineers that get PhDs in this stuff. And that becomes important for us sort of lay people in the fabric textile area, where we just want to know something that will work, right? And what the experts are saying is that one cloth does not equal another. There is variety, but there are some basics that we're going to be able to share, and we'll talk about to help enhance the chances that we pick what might be best out there. So protection and reduction of inward and outward flow, those of you who are cleared to wear respirators and have worn respirators in your life, there are some issues about fit and not just the filter. So for PPE, for example, personal protective equipment, protection's not only about the fabric use, but it's all about the fit. In fact, I go almost so far to say it's almost more important to have a good fit, to tell you the truth. I just want to let folks know I just lost my picture. So can you guys still see my slides?
Yes.
Okay, well, I'm just going to keep going, and then somebody else is going to have to take over advancing. So I'm on slide 6. There's a picture of a mannequin on the right with what looks like a surgical mask on. And I just made a point about fit. And then also for masks, there is a filtration fabric and a good fit to the face. And I think this is something we've all seen examples of people not having when we see people in public with certain types of homemade masks or other types of face coverings on. I think it's really important for folks to notice that probably the best example is looking at this mannequin, that air is going to follow the path of least resistance. And if you feel air escaping when you've got one of these masks on, that's where it's going to go. If your glasses fog up, your protection is low. So that means there can be air coming in and going out, and it's not going through the filter first, hence the problem. The smaller the particles, aerosols, the better they follow the airflow, which is bad for us, right? For either use of a mask, whether you're trying to protect you, the unknowing asymptomatic spreader, from spreading your virus, or if you are trying to keep from breathing in virus that's in the air, if the particles are small, which, as Dr. Sokas said, we now know they are smaller than we thought, they're going to have an easier time getting in areas of your mask that don't fit your face well. Okay, next slide, please. So here's just a choice, a potpourri of masks that are available on the market, and some of them look more like medical type masks on the left. And there are other choices on the right. The ones called facial coverings mean they're not respirators. And yet, I think a lot of smart manufacturers have tried to make face masks kind of look like medical masks to maybe imply that they work better. But they may or may not, depending on the filter material that they're using. It is true that if you are depending on homemade masks, there are good data to show that more than one layer of fabric gives you better coverage, and also mixing the type of fabric. In other words, cotton plus a synthetic, layered over top, sewn in together in a couple layers is a good thing. It is supposed to enhance both filtration and the electrostatic charge, and PhDs in textile science are actually hard at work at this now. Next slide, please. So this should be a picture of a man with a bandana on. I use this because when I see these in public, I run the other way. This is somebody who, although the face covering is pretty substantial, what's wrong with it? It's open on 3 sides, right? Both sides and the bottom. So this is not great. Having said that, the virus will take the path of least resistance, I think if this person has COVID, it's going to come to me because it's going to go out either side of his mask or down below. So I would suggest, if this is your preference, I think one simple thing you could do is, use the whole half a mask and make sure it's tucked into your shirt. But otherwise, I would suggest using something a little better. Next slide. This is just a shout out to NIOSH in terms of what's new and what's going on. Obviously, there is a need to look at face coverings and to really get a better handle on this, because even though we've talked about using the face covering primarily as a way for the unknowing asymptomatic spreader to keep from spreading their illness to the public, there are data that there is a little bit of protection for the wearer also. So someplace between 20 and 40% of additional protection might be for the wearer who comes in contact with virus suspended in an aerosol. So there is some protection going both ways. However, as I've already mentioned, we have a very mature science and expertise, especially at NIOSH, in terms of measuring performance for respirators, but not much on face coverings. So they convened a webinar at the National Academies of Science a couple weeks ago, and I'm on that work group that's working on this because this stuff needs to get clarified, because we obviously are going to have COVID with us for a while. Next slide, please. So what needs to be determined and is on the agenda for NIOSH's research agenda is to look at what the needs are for general purpose, general public community face coverings, and what would the standards look like that would define mask performance. And then we'd have to have an assessment program to measure performance against a standard for these non-medical but publicly available face coverings to make sure that they really do offer the protection that is implied by their manufacturers. So this is a work in progress, but that was a little update I wanted to share with you all on masks.
Hi there, thanks. I'm Chris Kane. I'm going to be moderating questions and answers. There's been a million coming in during the presentations from Eileen, Rosie, and Melissa. And we'll do our best to get to them, but we do want to wrap up at the top of the hour. So I'll just get started with a question for Rosie. What do you know about the long-term health effects attributed to COVID-19 that could have a significant impact on workers?
So there's not been enough history right now or enough long-term follow-up to really answer that question for sure. There's a lot of information, for example, after SARS and MERS recovery with fairly severe illness, that shows that there are prolonged time frames for recovery, that there's challenges with not only with respiratory recovery, but also with the debilitation that takes place anytime somebody's in. So I should start off by saying it's going to vary depending on the severity of the disease, right? And the question is obviously aimed at the really severe diseases where people are hospitalized, where they've got respiratory scarring potentially, where they might have myocardial damage, where they might have some neurologic residual, that kind of thing. And there are concerns particularly around people who spent time in ICUs, just because there's so much deconditioning that goes on. People have to get into respiratory and physical therapy programs to improve from that. So the answers haven't come in yet. Hopefully this will be a small percent of the population that have these prolonged problems, but we really can't know those answers yet.
Thank you, Rosie. Melissa, one for you. Can you talk about blood types as a factor that influences the risk or severity of COVID?
So that strikes a little close to home because I have type A, which they're saying isn't the greatest one to have for this. In reviewing that information, I found out, first of all, the evidence is mixed, which made me feel better. And also that there have been recent studies that are refuting this issue that blood type A is the best, and is the worst, and O is the best. Having said that, even the studies that talk about A being not the greatest one to have, did not find that having type A blood increased your risk of death. So that's a load off my mind. But I don't mean to take it lightly, but I think, this is new information. I think it's going to have to be kind of thought about, and more people are going to have to replicate it, although some of these studies, like I said, have been replicated, and some but not all are finding something similar. So for those of you wondering what the heck blood types got to do with COVID, I think the experts are thinking that blood type is a proxy marker for your immune function, and that might be one explanation. So that if you have a certain blood type, you are more or less strong in terms of your immune system's ability to fight this off. I'm very much oversimplifying this because it's not a light switch where you either have a good or a bad immune system. It's really multifactorial, but that's kind of what people are talking about.
I wanted to note that I put a note in the chat with a link to a NIOSH science blog and it's called it's related to source control and the use of masks and respirators. And it addresses, to the degree we know about, the use of an exhalation valve in that link I put in the chat for folks, because I got a couple questions in the Q&A on the use of exhalation valves in respirators or other masks. So Eileen, I actually had one come in for you too. The question is, does the planning tool allow users to access other CPWR sites, like the Silica Safe site, if they register?
It doesn't. We set these up as this one up as a very distinct website and planning tool, and the Silica Safe site was set up as a distinct planning tool. So if you register for both, your Silica plans will be in the Silica planning tool, and your COVID plans will be in the COVID planning tool. But it's something we can think about if there's enough demand. But it's just not how we have it set up now. Thanks.
Yeah, and we also have the firewall so we can't see the people who register and see their plans or their names. So that might be a little more difficult to do, but it's something to think about if we talk to the right developers. I'm going to go to Rosie next. So the flu season is coming. How will you know if you have COVID-19 or the flu?
Well, you probably won't. So the best advice is get your flu shot, get your flu shot, get your flu shot, and they're already available, which is kind of amazing because a lot of times it doesn't really happen until later in the year that the vaccine becomes available, but it's pretty widely available, so you can really start this month getting. And I would make it available to everybody that you have on your workforce, because even when there's no COVID around, there's really good documentation that if people are immunized from the flu, they're going to miss less work. You're going to wind up with a healthier workforce. They transmit less to each other. So it's a separate issue, but we've got a flu shot. Get your flu shot. The other thing is, with all of the other efforts that we're making to reduce COVID-19, if those are successful in social distancing and in other areas, then we might be fortunate and actually see a mild flu season, because you're not going to have all the exposures that you typically have. But that's a little bit of, that would be a nice side benefit, but get your flu shot.
Thanks, Rosie. Melissa, we've gotten a number of questions from individual workers or others who have asked about face coverings, and I can't wear a face covering because I have asthma or I have a health condition. Can you tell me some information, maybe the best resources or education information to address employee concerns about their other health conditions like COPD? And wearing face coverings?
I can tell you some information. I don't know about educational or, sources, but when some of our colleagues were talking about this together recently, one of the other ones said the people that think they can't tolerate a face covering are the very people that need to wear them. Now this starts to mix messages a little, because I just said, you know, that the main reason we wear the face covering is to prevent us unknowingly being an asymptomatic spreader, right? But I also told you that it does provide some protection. And two pieces of fabric face mask is pretty good for filtering out what would go through the mask itself. Now, I can say that people that think they can't tolerate one need to rethink this. This is not the same work of breathing as wearing a respirator to put a mask on. And the reason we say the people who say they have risk factors and think they can't tolerate them should wear them is because of the added benefit that they may get from wearing the face mask and it protecting them. So I would say that the resistance that a face mask causes is not significant for most people, including people with asthma, because quite frankly, as we know also, asthma comes and goes. And, you know, when you aren't having an attack, you are supposed to have close to normal breathing function. So I would really ask the folks that think I can't wear one, what do I do? I would ask them to find something they can tolerate, but that in general, the work of breathing through a face covering is not anywhere near as significant as the work of breathing through a respirator.
Thanks. I'm going to switch gears a little bit. One of the questions, several questions came in related to exposure. So what, I'm going to read you a few questions, and if, Melissa, you can maybe react to these as a group of questions. I hate to barrage you. You don't have to answer all of them, but is the exposure to someone with the virus for 10 or 15 minutes, is that exposure, or what is the definition of sustained contact? Is there a time limit associated with contact? You know, those kind of questions all came in together. There's several other. I'll stop talking now and let you actually respond.
Well, that's a really good question because, you know, we all want to know, you know, how long, how much, you know, did I cross the threshold or not? As Dr. Sokas said, there isn't a magic threshold for a lot of this. I can tell you in the hospital, we use the definition of 15 minutes. So, for example, one of my jobs during COVID was to help, you know, call back employees who had called in saying they weren't sure if they were exposed, but here's the story, and I called them up. And so our infectious disease people you have to make you know, a sort of decision, what's a, quote, quasi-significant exposure, and they decided on 15 minutes. Now, does that mean 14 no, 16 yes? That's not what we're saying. Biology doesn't work that way, so it's frustrating. But I think what they're saying is a drive-by exposure is not probably significant biologically. So you walking by of somebody one time is, you know, low risk. I don't know if that helps people or not. Is there more on that list you have there, Chris?
No, I think that's good. I mean, there was probably 6 or 7 questions related to that. What constitutes exposure? And this is for either Rosie or Melissa. You know, there's questions about testing and screening. So I guess the first one would be, what's the value of screening workers if someone can be asymptomatic? And by screening, meaning, you know, a lot of employers have implemented, as I think they should, temperature checks and symptom questionnaires, that type of thing.
I'm happy to, I mean, I actually, I think you're catching, so I have kind of a different reaction to that kind of temperature check screening. I mean, I don't think people show up with a fever and don't know they have a fever. So I think if you have paid sick leave, you get away with the need for that. So I would respond, you know, that this country should have enforceable paid sick leave. That's just, but you're going to at best capture. So every time, you go to see your doctor for anything, I mean, for when you go for your flu shot, you're going to get asked, to have your temperature checked. You're going to get asked all these questions about whether you've been on a cruise ship. I mean, it's like, but so you ask people, but I think, daily workforce where you've, and in my institution, they're asking those questions as well. When you go on campus, you have to answer all those things. But really, you're only going to capture half of the people or 40% of the people that you're worried about. So unless you're supplementing that with some sort of testing, then really it's it is fairly limited. So I'm again, I think if people are sick, they know it, and they should be empowered to not have to show up for work. And that means that they can put food on their table if they're not at work.
Thanks, Rosie. I had a couple questions come in real time. I can't get to them all. We're running out of time. But I did want to, a couple of questions came in regarding eye exposure. And it was basically, can you be infected through the eyes, and should eye protection be part of what people are wearing in general or on the work site?
So the answer is yes and yes. But it also depends on whether, in terms of what PPE you can tolerate on the work site. In healthcare, everybody has to have eye protection. We do know that the virus can get a foothold on a mucosal surface, and the pink moist part of the inside of your eye is what we're talking about. So that's a risk. Now, again, I'm not sure what each individual workplace, what the expectation is, the safety of eye protection, or if it's available or whatever, but you can get it that way. Having said that, we don't recommend eye protection for the public. So here goes the risk assessment at the workplace, right? What is the risk because of the type of work you do, or is the risk that of the general public, which might go to the decision-making about eye protection?
I would only add, I agree with Dr. McDiarmid, but I would only add that on construction sites, I'm not aware of construction sites that don't have other eye hazards as well. So really, construction workers should be wearing eye protection anyway, whether it's safety goggles or safety shield. Thanks.
I'm going to respond to one question that came in, and then I'm going to close out with a final question, I think, for Rosie. So one question basically, is there talk of OSHA developing a standard for this? And there's a lot of talk and a lot of pressure, but OSHA so far has made the determination that they will not be issuing a standard on that. There is legislation pending in Congress, and there are lawsuits pending as well to try to force OSHA to do that. But at this moment, they are not intending to issue what should be issued as an emergency temporary standard to protect workers from COVID in the workplace. That's my commentary. And I'm going to wrap up with a question on vaccines for Rosie. And there's really a couple of questions, and it's hopefully you can, I'll just shoot them out and you can answer them. Will having an approved vaccine, what will having an approved vaccine mean for the spread of COVID-19? Will everyone need to be vaccinated? Is it possible for one vaccine to work for everyone, or will people need multiple ones? If you can respond about the COVID vaccine issue.
Yeah, so the COVID vaccine, as everybody I'm sure is following in the news, there's about 120 vaccines that are in some phase of trying to look, and there was there's a little hiccup right now in one of them in terms of a side effect. So, the herd immunity was the answer to that question. You want to have enough people immunized with an effective vaccine. Now, vaccines can range in effectiveness from 50% upwards, so it's not like they're 100% effective. And it may well require 2 doses, especially as people age and have less of an immune response. So the vaccine is very much on everybody's mind. It's going to be the final answer, but we don't know when we're going to get to it. And there are lots of people throughout the world working on it right now. But yes, most people will have to be immunized. It's not going to have to be every single person, and there's probably going to be more than one dose, but we don't really know. Quick response. Virginia has passed an emergency temporary standard for COVID-19. Hooray for Virginia. They're a state plan OSHA state, and California has been issuing citations for COVID-19. So that's been 2 places at least that have made positive steps.
Great, thank you, Dr. Sokas and Dr. McDiarmid and Eileen Betit and Scott. Dr. Ernest, I want to thank you all for participating today, and we do have more questions than we can answer. We keep track of these for everybody who's still on the line. We have over 300 questions that have come in, and we use them to form topics for our future webinars, so stay tuned. Our next one should be in 2 weeks, and I appreciate everybody's time today. I know everyone's busy. Thank you.